Out goes the graft. Intraoperative challenges in descemet membrane endothelial keratoplasty and how to tackle them. DMEK is the only surgical procedure that provides a true anatomic exchange of diseased endothelium and descemet membrane with healthy donor tissue. In contrast to DSEK, no additional stroma is transplanted. DMEK provides better visual acuity and lower risk of rejection in contrast to DSEK.
Graft preparation, graft unscrolling and centering were identified as the rate-limiting steps by majority of the surgeons in DMEK surgery. Every DMEK operation is an exercise in problem solving. This video takes you through the steps of DMEK procedure combined with fecal emulsification in a small pupil and the intraoperative difficulties faced by the surgeon and suggests techniques to overcome them.
The first step in our surgery is making of the primary incision. It is followed by making paracentesis incision. Iris hooks are inserted to expand the pupil size, followed by injection of trypan blue dye to stain the anterior lens capsule. Capsulorrhexis is done using reverse Sinskey hook over 360 degrees prior to fecal emulsification to improve clarity intraoperatively. Anterior capsulorrhexis is being made. It is followed by hydrodissection and fecal emulsification of the nucleus using direct chop technique. The nucleus is being fragmented and fecal emulsified. After cortex aspiration, PCIOL is injected into capsular bag. This was a case of Fuchs endothelial dystrophy. The epithelium was edematous and was therefore removed. A peripheral surgical aridectomy is done with Varna's scissors. The scored, floating descemet membrane is being stripped away. Donor corneal button is trephined with a 9 mm trephine. Donor button stained with trypan blue dye. Excess of the dye is blotted out. Gentle dissection and separation of descemet membrane from posterior stroma is done in the periphery of the graft. The graft is being harvested very gently and slowly to avoid chances of tearing of the graft. The technique used in this surgery for graft preparation is scuba technique, submerged cornea using backgrounds away technique. A 3 mm punch is used. Donor corneal button is flipped. S mark is applied, which helps in confirming orientation of the graft during graft insertion. Graft is trephined with an 8 mm trephine. Repeat staining is done with trypan blue to highlight the liftable edge of the graft. The graft is slowly being peeled away from the posterior stroma. S mark is visible on the underside of the graft. Once the graft has been completely separated, we can see that the graft will now assume a double scroll configuration. The graft is aspirated into an Alcon B cartridge. Surgical incision is being enlarged. The graft is being injected into the anterior chamber. But oops, the graft gets ejected out. The graft is reaspirated into the cartridge, and the graft is now being reinserted into the anterior chamber. But oops, the graft gets ejected out again. How can we prevent the graft efflux? Releasing fluid from a paracentesis prior to withdrawing the injector or at any time the surgeon feels the eye is becoming overpressurized. Additionally, shallowing the anterior chamber after graft insertion and prior to injector removal can maintain graft orientation and simultaneously begin the unfolding process. Another technique for reducing graft ejection is by pressing a second instrument atop the main incision while withdrawing the injector, essentially creating a trapdoor at the wound. The primary surgical incision size should not be larger than the size of the injector. In this case, the primary surgical incision was larger than the size of the injector, which left space for the graft to be ejected out. A single suture was taken to reduce the size of the surgical incision and provide a snug fit with DMEK injector and thereby prevent fluid egress and egress of the graft with it. The graft is reaspirated into the cartridge and is now being re-injected into the anterior chamber. This time around we can see that the graft does stay inside the anterior chamber. Graft insertion can also become a rate-limiting process as evidenced in this surgery. So proper construction of primary surgical incision is very necessary. A combination of balanced salt solution, air, shallowing of the anterior chamber, tapping and stoking can be used to unroll and center the graft into position. A second suture is taken. Gentle stokes and taps are used on the anterior corneal surface to help unfold the graft. A stamp is clearly visible on the underside of the graft, confirming correct graft orientation. A burst of BSS is used to indirectly manipulate the graft into position. Once the graft is positioned, air is injected in between the iris and graft and allowed to stay for 60 minutes, that is followed by air fluid exchange. This is a picture of the post-operative day 1.